One day we won't wear those. I need to be negative to come back to Canada, so I wear it a little bit more often than others. So for those of you who came late, we'll take all the questions at the end. So all the panel will come up at the end, and we'll try to answer the questions that you might have. So our next speaker is Dr. Mette Deleuran, who will talk about allergic contact dermatitis in atopic dermatitis patients. Something we see fairly often, not always easy to evaluate, always hesitant. When I have a patient that I consider does not have allergic contact dermatitis, and then there's a flare somewhere, is it allergic contact dermatitis? Should I send the patient to somebody for patch testing?
Thank you, Robert, for the nice introduction, and thank you for inviting me to give a talk on this topic, which I find very interesting and a little different than when we normally just see AD patients. These are my conflicts of interest, and I work a lot with companies regarding atopic dermatitis and new treatments. And considering atopic dermatitis and allergic contact dermatitis, we know that it impairs quality of life for patients, both children and adults, and also for their families. It interacts with social relations, and sport activities may be inhibited. It's difficult to do your hobby if you're allergic to something. You have to consider choice of occupation. And in our eczema school, we teach the parents that they should consider when the child is growing up what to do with the occupation, because they need a clean and dry work, and also to prevent them from getting allergic contact dermatitis on top of their AD. And I think it's very important to recognize both diseases to try to alleviate the problems for the patients. Allergic contact dermatitis in children was earlier considered to be rare. People thought that the immune system of children were less developed and children were less exposed to allergens. And of course, we know now that they are really heavily exposed to allergens. And I'll come back to that a little bit, but there's perfume in everything. They touch a lot of chemicals in their everyday life, and it can induce allergic contact dermatitis. And people thought, well, maybe it was mainly AD and seborrheic dermatitis, but we have to recognize also allergic contact dermatitis. So many studies have dealt with this problem. This is a study we did in 2018, where we looked at 800 children and adolescents with AD, and 30% had at least one positive patch test reaction when we tested them. And they also had a high number of currently relevant allergic contact dermatitis. 17% were actually diagnosed concomitant allergic contact dermatitis. Another study, 500 children with AD and 400 without AD. It's a Dutch study from Thomas Rustemeyer's group, and they found that equally numbers, 46 and 47% of patients with and without AD had at least one positive reaction. And they found that sensitization to fragrances and lanolin alcohol were more frequent in AD patients. And I think we asked the companies for many years from the Nordic countries, could you please not add perfumes into the products? Now we are having a success with it, I think, to some extent, but in the earlier times, people thought, well, it's always nice that the cream smells nice, and of course it is, but if you get an allergic contact dermatitis, it's not so good. And this is a Swedish study looking at hand eczema in AD patients, where they saw that if you have hand and foot eczema, you should maybe test more often to find relevant allergic contact dermatitis reactions in children also having AD. So this is an Italian study. Many have been interested, and I think it's a good idea. 350 children between 0 and 15 years of age, 1/3 had AD, and patch testing was performed with 30 allergens. When you read these different studies, that people do it differently, and they also have different panels, and Aaron is nodding because it can be a challenge to find out what was going on, but we all have different panels. Also around the world we have different panels for patch testing, because some local factors can be more prevalent for allergic contact dermatitis in some regions than others. But they found indeed that patients had a lot of positive reactions, both children with AD and children without AD. the prevalence was higher in the non-AD children, and I think that's because you get a higher suspicion to do the contact dermatitis testing, because if you have not AD and you suddenly develop facial eczema or hand eczema, you have a higher suspicion of testing them. So just to say, is this only AD? Well, we don't know before we actually tested the child, and she also had a contact dermatitis. So we did a reasonably large study in Denmark because, you know, it's such a well-regulated country. Everybody has a CPR number, so we can put things together because we all of us have a personal code for who we are, and we have a collaboration participating many departments in Denmark and also private practice who report into this database, and we had 2,600 patients. 2/3 were girls, 1/3 were boys, and they were between 1 and 17 years of age. And they all suffered from eczema or atopic dermatitis or contact eczema. We didn't know before we tested them. Of course, we knew who had atopic dermatitis. They had treatment refractory eczema, and they were suspected to have allergic contact dermatitis. And they were tested with the European standard test series or true test, supplemented with additional allergens relevant for the patient's history. And I think that's really important, that you add the products that the patient use at home. Maybe they go to some sport, maybe they do something with glue in their spare time, or you have to have a really good patient history to find out what is relevant to test with on top of the standard series. So 23% had hand dermatitis, 24% had facial dermatitis, so it's really prevalent that you have a lot of hand eczema and facial dermatitis, exposed skin areas. Not so many had legs and feet dermatitis, and the rest was unknown because it was not registered. And the result from this testing was that 1/4 had at least one contact allergy, and for 2/3 of these, it was considered relevant compared to their history. The most frequent allergens were metals, fragrances, dyes, PPD. I'll come back to PPD because it's really important to recognize, glues, and rubber chemicals. And regarding contact sensitization, if you look at the bottom of this slide, you can see that there were a little more irritant reactions in the AD patients, and I think Jonathan Silverberg will cover that in detail because they have this open skin barrier if you have AD. And we also tested for topical corticosteroids, and I think when you that it's a little contradictory that you can be allergic to a topical corticosteroid because it was supposed to treat your disease, but it is relevant. But fortunately, not many children reacted to the steroids because we would like to have them in our armamentarium to treat the children with them. But I think it's very important if you test with topical corticosteroids that you do a late reading, because in the beginning, the immunosuppressive mechanism of the product will prevent patch testing from developing, so you have to get rid of that first before the contact allergy comes in. And therefore you have to read topical corticosteroid patch testing at day 7 or later. And also ask the patient if they have a later reaction, take a photo and report into you. So that's sort of, we continued doing something, and we would like to see what has everybody found, and we published this paper in 2017 where we included 31 studies out of 436. You can see the exclusion criteria on the right side in this systematic review regarding contact allergy in children with atopic dermatitis. And it's Anne Birgitte Simonsen, who's now a consultant in Gentofte, who was the main driver of this study. And a total of almost 16,000 children were tested. And this is a forest plot that you can see there was a little less AD patients who were sensitized to at least one allergen compared to children without AD, but a highly significant proportion of the children, both with and without AD, were actually sensitized. So our conclusions from this study is that contact allergy is a significant problem in children with AD and should always be considered in cases of treatment recalcitrant AD. And children may have unacknowledged contact dermatitis, which is contributing to their symptoms and worsening their atopic dermatitis. And we also found in this systematic review that they have a greater risk of sensitization if they already have AD. They have to certain allergens, especially components of skincare products, very naturally because we apply it on the child's skin all the time to prevent the dryness, and also to metals. Patch testing children can have some challenges, small areas of skin, which allergens should be tested for. Is it safe to test children? Do you risk to induce allergies in children? Because we would, of course, not like that to happen. And we think that children can be tested in the same way as adults. The same concentrations of allergens can be used, and the high rate of negative patch tests and the low number of irritant reactions support this view. But there is a concern about paraphenyldiamine and epoxy. So what about these black henna tattoos? Many children from Denmark and the Nordic countries, they go on vacation in the south, and on the beaches they get a henna tattoo, and it's not a good idea. So tell your patients not to do that. This is a positive reaction for paraphenyldiamine, and it's a very heavy inducer of allergic contact dermatitis. And the problem is that if you get a paraphenyldiamine reaction, you cannot dye your hair in the future, and I think most people like to dye their hair. In many hair dyes, they contain paraphenyldiamine, so it may prevent you from getting another hair color in the future. So don't get a henna tattoo. Actually, I had a child who came from the Department of Orthopedics with a big bulla, and they thought it was necrotizing fasciitis, and it was contact dermatitis, so steroids instead of surgery. But you have to be careful, I suppose. He got a long scar, but was okay in the end. So you can test them with the patch test series and selected allergens guided by the patient's history and localization of the eczema. And you should read also late day 3 and day 7. And you can also test on the arms and the thighs or do it in different sessions. So which factors are relevant in children? Well, there's a long list of this here: metal, skincare products, natural remedies. Many parents think that if they buy it from a natural shop, it's harmless, and you should really be careful because there can be a lot of contact allergens in natural products. Black henna tattoo, shoes and shin guards and diapers and some toy cosmetics which are not always regulated what the content is. So this is just an example from my colleague Mette Deleuran, who is an expert in allergic contact dermatitis. She tested this boy with a table tennis bat, and as you can see, he had positive reactions to both rubber chemicals and also to the bat itself. So this is a real nerd testing, you could say, but relevant. I would like to show you some examples of what we find in the clinic. This is an 8-year-old boy with atopic dermatitis. He had it since 3 months of age. And the last 2 years, he developed eczema on hands and feet in the summer very badly. In the wintertime, it was almost calm, but in the summertime, it was really difficult to treat with potent topical corticosteroids. And we put standard series, shoe series, compositor series, and own products on his back. As you can see, he had a lot of different allergens on his back. And what we found was that he was polysensitized to all the metals, formaldehyde, and the sesquiterpene lactone mix. And we titrated it out, and many different flowers he was allergic to from the compositor family. This is another girl. I followed her since she was a small child, and she also had treatment refractory AD and exacerbation of eczema in the summertime on the hands and on the face. Her mother was actually a gardener, and I don't know if that contributed, but as you can see, she had several positive reactions toward flowers from the compositor flower family. She's now a grown-up young woman, and one day she came to me and said, I want to study biology, and she went to the biology department to study, and I was just very worried because I thought, well, all that contact with the plants, it's not a good idea. But last time I saw her a month ago, she said, well, now I'm studying to be a dietitian. I said, well done, because I think that was a better choice. There's an association between AD and contact allergy to composita. They are airborne allergies and they can imitate atopic dermatitis. The thing is, and the trick that you should think about this is if there's a summer exacerbation, because normally AD gets better in the summertime. And dandelion is actually an important sensitizer for children. It's safe to test children, and be aware of composita and natural products like this nappy change cream, which had some composita components in it. So just because it's a natural product, it's not safe all times. This is another important sensitizer, methyl isothiazolinone. I'll call it MI because it's difficult to say. This is a case published in 2013 on an airborne contact allergy. It was a 4-year-old girl who had mild eczema, atopic dermatitis, and she developed an eczema on her face, followed by generalized eczema. And her room had recently been painted with a water-based paint containing MCI, which is methyl chloroisothiazolinone, and MI. And after 4 weeks, it got better because I think the vapors from the paint was wearing off. But she also had a diaper dermatitis in the past, and many parents use these wet wipes for children. And it's important to know that there's MI in some of them. We now have a legislation in Europe, I don't know if it's the same case in other parts of the world, where it's not allowed to put MI in leave-on products, and I think that's a good thing. And actually the percentage of patients with positive reactions are going down regarding MI in Europe at least. So I think it's really important, like with the nickel regulation, that we take care of these things, and as doctors tell the legislators to be aware of these problems sometimes with the products. And this is an adult who had AD and also a cathon allergy, which is a mixture of MCI and MI. So he had a hand eczema, and he was a professional painter. Also, contact allergy towards medical equipment can be a problem, and I think you should be aware of it because many patients use these glucose sensors and insulin pumps, and of course it's a revolution for the patients with diabetes, but sometimes you get contact allergy from these medical devices. And we had a patient who had, in May 2017, an insulin pump, and it was changed every third day. And in August, he got an itch and erythema, and in November, he had eczema on the abdomen where the pump was situated earlier, and he was treated with topical corticosteroids. And patch testing revealed that he had a sensitization towards different acrylates. And I recently found this very new paper, 3 cases with allergic contact dermatitis towards acrylates in the adhesive material of the insulin pump. And it is an increasing problem, both in patients with AD and without AD. And often it is very difficult to obtain direct instructions about what they contain, and sometimes the batches changes from time to time. So sometimes there are some acrylates in the product, and next time there will be different acrylates. So there's a risk of polysensitization among users. So be aware of that, and it's really a tedious work to ask the producers about these allergens, because normally, sometimes they won't tell you properly, or sometimes they don't know maybe. But what about adults? So far I've spoken mostly about children, but I think it's the same problem with contact dermatitis in AD patients, in adult patients. This is a study of almost 5,000 patients, and half of them actually developed at least one positive reaction when they were patch tested, AD patients with and without AD. And there was, in this study, the overall prevalence of contact sensitization was not significantly different between patients with AD and without AD, and AD patients were less likely to develop contact dermatitis to budesonide and ceram mix, which is the rubber chemicals. But they were more likely to develop contact allergy to potassium dichromate. It's the metals again, with sometimes is a problem for AD patients. And if you have a difficult to treat patient has a difficult to treat AD, you should be aware that you should test them. And in this study from Amsterdam, they showed that 71 of whom had at least one contact allergy, and 40% had more than 3 contact allergies. The patients with AD are often polysensitized. And this is a test. This is a study from Boston. I thought that now we are in Boston, we should find some results from there. It's from Mass General, where they tested a lot of patients, and the most common sensitizers were similar in both groups, suggesting common source of sensitization, whether they had AD or not AD in the past. This is another case from the International Journal of Women's Dermatology, a very good journal. And this is a woman who had AD lifelong, and she then had a flare on her face. And as Emma mentioned, there can be other causes of facial dermatitis than just AD. And she was patch tested and had 2 quite positive +2, which is quite positive reactions to many of the ingredients found in her daily care products. So please bring in the patients what they use in their everyday lives, because there can be allergens in it that is relevant for their flare of AD, so to speak. So she had an atopic dermatitis with contact dermatitis on top of it. Possible complications of patch testing, I know maybe Jonathan will tell you more about it, but it can be that you have a small risk of active sensitization. You can have irritant reactions from inadequately diluted patient's own products. So be aware of that, how high a concentration of a product you can put on the back of the patient. They can also have flare of dermatitis at the site of patch testing, but also flare on sites where they normally get the eczema. A classical example is if you test a nickel-positive patient, they get a flare of their hand eczema. And they can also have persistent patch test reactions, and of course you should treat them with topical corticosteroids after the testing if they have severe reactions. And hyper and hypopigmentation can be a problem, especially in patients with skin of color. What about dupilumab? Does it interfere with patch test results? Well, maybe it does and maybe it doesn't. And I think we all use dupilumab, and I had patients who almost cleared on dupilumab, and I thought we have never been able to patch test them before because they always had eczema on their back. But now we have the chance, because I thought maybe it does not interfere with the testing. And I think there are sort of different evidence, and it'll be interesting to see in the future if there is a problem with dupilumab or not. This is a study from Jenny Murray's group, and they tested patients with patch testing before and on dupilumab treatment, and they found that only 10% of the patch tests were lost on dupilumab treatment. So they conclude it's not a problem to treat with dupilumab. And maybe not, but there's another study from 2021 where they had 20 AD patients. It's from the Rotterdam group, and they found that only 29% of positive patch test reactions were observed before, which was observed before dupilumab was still present and re-elicited in the patients using dupilumab. So it will be interesting to see what the results will show in the future, whether you can have patients on dupilumab or not when you patch test them. So consider patch testing if the eczema is unresponsive to treatment, it is present on unusual parts of the skin, and the patient suffers from chronic hand, foot, and facial dermatitis. And I think patch testing in both AD and non-AD patients is relevant. You should test them with single series, supplemented with single allergens chosen from the patient's history, location of the eczema, and exposure analysis. And you can also additionally test patients with cosmetics, hair products, skin care products, topical treatments, whatever they use in their everyday life. And additional testing with work and hobby-related allergens is also relevant. It's a little difficult and a little tedious, and you have to have all these product sheets, but it's worthwhile. We find a lot of allergic contact dermatitis in this way. So allergic contact dermatitis is a relevant diagnosis in patients both with and without atopic dermatitis, and it occurs in all age groups. And finally, I would like to acknowledge my co-workers, Mette Sommerlund, who is my colleague in Aarhus, Charlotte Mertz from Odense in the middle of Denmark, and Janne Dus Johansen and Anne Birgitte Simonsen from the National Allergy Research Center in Gentofte. And thank you so much for your attention.